Okay, have fun.
Yeah,
It's
see ya.
nursing process. Woo-hoo.
Okay, yes.
What's the review code for the exam?
The review code
Yes.
was review it all together.
I think
I think so. Let's review it. That's the only one I made. It worked for me. All together, no space, all lowercase.
It's not working. I don't.
Alright, I'm gonna move on here. Alright, assessing. So we're gonna go through now and talk about assessing, diagnosing, planning, implementing, and evaluating. Okay, some concepts that you should know front and back. Okay, so assessment we talked about is systematic. Okay, so we do our vital signs, we get our health history, we do a physical assessment. Okay, it's continuous. Okay, so we're never like, my assessment phase is over, so I didn't notice that my patient fell down in the home. Okay, we're always assessing, okay, collecting data, okay, vitals, assessment data, labs, subjective information, things that the patient is telling us, observation of the patient, if they look angry or sad or confused. Okay, in that assessment phase, we're also analyzing that data. We're not just collecting it, we're thinking about it critically. We are validating it if we get something that we think is wrong. So I get a blood pressure that is, 200 over 100, but the whole time I was doing it, with the electric blood pressure cuff, they were moving their arm around like this. And it took 4 different times to pump up, and it took 5 minutes, and by the time I got my result, it was 200 over 100. Okay, well, you can't do that. You have to tell them to keep it still and not move it. That blood pressure reading is inaccurate. Okay, so you need to validate your data. Communication of that data or information. Okay, so it includes communication, so documenting. So while we collect the data, we should be documenting the data. Okay, if you work in the hospital, you can scan into the vital signs machine, you can scan to the patient, you can get your vitals, press a button, and boom, it's documented. Usually for us students, we don't have that option. We can't log in, so we have to pull up the computer to manually put it in. Okay, if we're nice, we should also write it down. Maybe write down 2 copies, give one to the aide, give one to the RN. Okay, so that everybody has the information, because we're not automatically connected, doesn't automatically pull us through, but everybody else still needs to know about that information. Assessment. So we do the nursing history. So a lot of the times in the hospital for clinical, we kind of already know everything, right? It's not our first time having them in the healthcare system. They've had a history and physical done. They have progress notes for the physicians. So it's not like we're gonna have to collect all their history, we just have to review it, it's in there. So part of our assessment phase is looking at that information in the computer. Okay, so we're identifying their health status, their problems, any risks that they might have. Okay, so when we get to the diagnosis phase, you'll see there's some that say risk 4. Okay, so that's a risk diagnosis. It's not an actual diagnosis, it's a potential diagnosis. But if they qualify and have that risk 4 diagnosis, then there's a plan that we should put into place for them. Okay, it's also our physical examination. We can also use the patient's family. Okay, maybe the patient is forgetful and quiet or in pain or whatever, and their wife or significant other, son, somebody can fill in the gaps and give you information. Okay, we have to be able to validate, is that a good source of information or is that not a good source of information? Okay, so you have to evaluate your sources. If they're helpful, recognize them as helpful. Don't complain about the family talking to you, they're part of the patient's care too. Okay, if they're not helpful, we need to get them out of the situation. record. We talked about other healthcare professionals, so you'll get a nursing report. You can read like physical therapies and occupational therapies notes to see exactly, so it looks like, so it's 6 a.m. today, it looks like at 5 p.m. yesterday, physical therapy got this patient up to the chair for dinner. Okay, so I can anticipate that physical therapy is gonna be coming in and my patient's gonna be able to be transferred to the chair for meals. So that should be my goal for their breakfast time. So lots of sources of data. Okay, so for us, our assessment data may contribute to a medical diagnosis, but we're typically not trying to figure out a medical diagnosis. We're not the physicians, they're already diagnosed by the time we see them. Okay, it's part of their chart, we know they're admitting diagnosis. So again, we are focused on their response to actual or potential health problems. Okay, so if you look at your nursing diagnosis, they're descriptions of problems, okay? Not specifically usually a medical diagnosis, but a description of a problem related to that medical diagnosis. Okay, because we are concerned with how they're responding to that illness. Okay, what are their vitals, what are their abilities, and how can we improve them? Okay, there's different types of assessments, and I'm actually gonna go from the bottom up on this slide. So first of all, like I said, we are going to document our vitals. Eventually, as we get into clinical, we'll document our assessment on the documentation system. We never want to falsely document data that we did not actually collect. Okay, that's huge. So if we didn't do it, we can't make something up and put it in the chart. Okay, if somebody else does an assessment, we can't document it for them. We need to document their own assessment. Okay, you don't want to document ahead of time. Okay, so you might see this a lot in nursing homes. We have 30 patients that each take 30 pills that we have to give, and instead of going down and in each room, getting their meds ready, they'll sit at the nurse's station and they'll pull them out in med cups and set them all out and have them ready to go, so then when they walk down the hall, they can just hand them to their patient. Okay, technically, really, you're not supposed to do that. Could that be ever done safely? Sure, I think it probably could, but it has more potential to be unsafe. Because some of those medications, we have to do a pre-administration assessment. So we have to know maybe what their blood pressure is. So if I dumped all these meds in there and I finally take their blood pressure, well, I can't remember which one is the blood pressure pill, so how can I take it out? How can I be sure what I'm giving them at this point? Okay, so they'll document that they were all given before they go and give them. And then what if your patient, drops dead and you've already documented that you've given all their medication? That's not gonna look very good for you. Okay, so we never document ahead of time, we never document something that we don't do. Okay, there's an emergency assessment, which you would see in the emergency department setting. So it's a rapid and it's focused on life-threatening or unstable situations. Okay, your BLS training for CPR is an emergency assessment that you do. You see if they can answer you, you see if they have a pulse, if they're breathing, and then you step into action. You don't ask them their name and their date of birth and their medical history. It's an emergency assessment. Okay, a focused assessment you might see more in a doctor's office. Okay, so you come in for a specific problem and that doctor does a focused assessment. The nurse who checks you in gets your vitals and asks you a couple questions too. Really, the doctor is going to come in and look at that data and really figure out what's going on. So a focused assessment. Okay, something that we do commonly is an ongoing partial assessment. So like your shift assessment. Okay, so we do a head-to-toe assessment, but I mean, we're not checking their cranial nerves and checking, their scalp every time we come in the room. They're admitted for chest pain or pneumonia. We're gonna do an abbreviated head-to-toe assessment, but it's a very focused assessment on their abilities, their vitals, heart sounds, lung sounds, range of motion, pain type things. Okay, the comprehensive assessment is going to include the physical assessment and a health history. Health history and physical assessment are separated because health history is subjective, physical assessment is objective. Okay, health history is asking the patient what brings you here, how have you been feeling, things like nausea are subjective. Okay, physical assessment is the vitals, head to toe assessment. Okay, so put that all together and that's comprehensive. Okay, comprehensive is usually done when they first enter a healthcare setting, have to get all the information. Because of technology today, now all that information is saved, so every future occurrence with the healthcare system, you have that database and you don't have to go and do a whole health history because it should be there. Okay, by the time we see our patients in clinical, they're admitted to a hospital, they've had a complete physical assessment by a physician and it's documented in the computer for you to see all their lab results. They'll spell out exactly what the problem is, how we know that's the problem, and what their plan is, what medications will be given. Okay, so that's something that you will look at when you go and see your patients. That's part of your assessment, is looking at their assessment data. All right, lots of slides through here about how to give a caring interview. If you read in chapter 2 about subjective assessment, there's 4 phases of the working relationship with an RN and a nurse. So there's a pre-introductory phase, an introductory phase, a working phase, and then summary or closing or termination phase. Okay, so you can pull those out of your health assessment book. That will come into play again when you guys learn about communication, when Kathy teaches that. What's that coming up? Okay, we'll talk about it week 5, and then we'll talk about it again week 6. Okay, so week 5 on Tuesday, we'll talk about communication and documentation. And then on week 6 on Wednesday, we'll talk about caring interventions. So there's 4 phases of your relationship. Pre-intro is when you review the medical record. Introductory is when you go in and introduce yourself, explain your purpose, let them know that you are going to protect their comfort, their privacy. You want to sit at eye level if you can when you first go in to talk to the patient. Okay, and then you have a working phase. So collecting your data and your critical thinking, and then summary or closing. So, okay, so here's our plan. Do you have any questions? Do you have any concerns before I leave the room? Okay, so you want to set up that relationship the first time you enter the room. Make sure that they know that you're somebody who's organized, who they can depend on, and that they're not going to be hammering on your call light, harassing you all day long, because they know that you're going to be in there taking care of them. You've answered all their questions. Okay, so you need to make sure you're organized, have everything with you. I should have brought my clipboard, but on Amazon you can get a clipboard that folds in half and fits in your scrub pocket for like $15 or something. They come in all different colors, and they have reference stickers on the backs and sides of them with lab values and things like that. Okay, because you're not going to have anything for infection control that you want to carry in and out of the rooms. Anything you take in and out of the room should be in your pocket. Okay, you can have, you'll have clinical folders with all your worksheets. Those can stay out by the nurse's station or in the break room. Okay, so have your stuff with you. You know you're going to get vitals. You know you're going to do an assessment. Okay, you can either pull up the computer in the room and follow the flow sheets, or you can have it written down and copy notes back and forth. Whatever you're going to do, have a plan. Don't rely on memory. Make sure you have privacy and a quiet environment so that the patient can focus on your assessment. Those. We talked about this. You have to introduce yourself. I'm Gretchen. I'm a student nurse. I'm going to be here helping out to take care of you today. I always like you guys to reassure them that they still have all their other staff and they don't have any less responsibilities because we're there. We're just extra. Okay, we're extra help for you today. So make sure they know that I'm going to be doing your vitals today. I'm going to be doing your medicines later. You know, I'm going to make sure you get up for breakfast, make sure you get your bath and anything like that, your oral hygiene, all of those things. You can verify their name. Make sure you know what they like to be called. Hopefully their whiteboard in the room is up to date. Okay, try to give them your attention. If you can try to do both at the same time, it's okay. Just make sure that you never have your back to your patient while you're working at the computer. Okay, do not talk to them if you're not looking at them, okay? I killed my daughter the other day. She's yelling at me from another room at the house, asking me a question. I'm just like, are you talking to me? We're not even in the same room. Come in here and look at me. So make sure you don't ask your patient, you know, are you having any pain? Okay, where's your pain? How bad is it on a scale of 1 to 10? Don't do that. It's obvious that you're not really interested if you're not looking at them. Okay, listen actively. So we're looking for nonverbals. Remember, we're going to be creepy and stare at people all the time, okay? We have to observe them and see if the nonverbals match what they're telling us. Okay, so like if there's something that's contradictory in this example, try to be diplomatic about it. You say that you aren't having pain, but you look uncomfortable to me. Okay, so we could just say, you know, if they're sitting there, they're in obvious pain, and they say, I don't have any pain, we could say cool and move on. But then as soon as we leave the room, they're gonna have their call light on, and they're gonna tell you that they have pain. So just whatever, a lot of people that are hospitalized frequently need a lot of attention. Okay, so if you just take your time and pay them attention, they'll be easier to take care of the rest of the day. Okay, use short, simple phrases. So like even when you identify them, don't say what's your name and date of birth. Say what is your name and then wait for it, and then what's your date of birth and wait for it. Okay, because some patients that's too much. Okay, so split it apart. If they're thinking about something, try not to speed them along. For all of clinical, you only have one patient. Okay, you have plenty of time to listen to them, and then you'll get good at picking up verbals and nonverbal, and you'll get quicker at finding out what you need to know to take care of them. Okay, try not to interrupt them. Silence is okay. Silence on your part is better than making something up or saying something silly or laughing or trying to make a joke. Just be silent. Just sit there and be silent with them. That's okay. Okay, what's the plan for today? You know, was the doctor in today? What did they say? What's the plan? Is a good way to start communication with the patient. Okay, using open communication, tell me more about this, that, or the other. Okay, we can restate, and again, you'll have these when we talk about communication. Restating, so I think this is what you said to me. Do I have it correctly? Am I summarizing it? Do I know the main point? Okay, we talked about this. Okay, we talked about that. Okay, so once we've collected data and we've identified problems, we're going to think about how we need to prioritize them. Okay, so what is their need for nursing? Is this a patient who is going to be here probably for a long time? Or am I looking to get them well enough to go home? Am I thinking about discharge? So where are they at? Okay, these are developmental stages. So for adults, intimacy versus isolation. Older adults, generativity versus stagnation, and then the oldest, integrity versus despair. So psychologically, this is what they're dealing with, depending on their age group. Okay, so have an awareness of that when you're communicating with them. Okay, and then culture and religious beliefs. If patients have any specific religious beliefs, they're questioned on their assessment, their admission assessment. What else? The best thing if a patient doesn't speak the same language as you is to have an interpreter, if at all possible. And I know hospitals do use, but is it Marty? The thing that's like a computerized interpreter. Okay, so best case scenario, get an interpreter. If not, have to find some resources that you can use to communicate. Okay, when doing an assessment, you can use this, especially as a beginning student nurse, so the HELP guideline. So every time I go in the room, first thing in the morning, so H is for help. So when I first go in there, make sure they're stable. They're not in pain, they're not having trouble breathing. Okay, if they're sitting there like this, you can't say, hi, I'm Angie, I'm your student nurse today. I'm gonna get your blood pressure. You know, they can't breathe. So you want to address that problem. You want to notice that. Pain has to be addressed before you can talk to them. Okay, look around the environment. You're gonna see things like oxygen, IVs, and catheters. Okay, always be on the lookout for those. See where they start and where they end. Follow the connections. So even if you haven't learned about something yet, if there's something connected to your patient, you need to follow it and make sure it's connected properly. Get help if you don't know how. If they're supposed to be on oxygen, make sure their oxygen is on. Check the setting. Same thing with IVs. Follow it. You're going to make sure that that site is not painful, swelling, leaking. Also, telemetry monitors. You'll see most of our patients will have, they'll have 5 electrodes on their chest connected to wires and then a little box in their scrub pocket. And then it's hooked up to a monitor up at the nurse's station and you can see, you know, their cardiac cycle, their heartbeat. So before you even go in the room, if your patient's on telemetry, you can look at the monitor. Oh, my patient's heart rate is 66. That's awesome. Or, oh my goodness, my patient's heart rate is 120. Can somebody come in there with me? Because I'm not sure what I'm gonna find when I go in there. Okay, and then look, when you do your assessment, make sure you do a thorough assessment. Especially as a beginning student, you might need help, 1 or maybe even 2 people. Especially if your patient is big or has limited mobility, you really need to make sure you look at their backside, underneath any folds, inside any crevices, and make sure you get an accurate, complete physical assessment. Okay, and then people, who are the people in the room? So when somebody comes in to see the patient, that doesn't mean it's time for you to leave the room. It's time for you to listen and learn from the interaction taking place between whoever is in the room. So you should know what that patient did all day long. A lot of times we'll come in and you need to have your instructor with you for certain things, and then when we're done doing that certain thing, I have 8 other students and patients that I have to go help. So I'll, you know, wash my hands and excuse myself, and then sometimes students just follow me right out the door. Well, you have a lot more work to be done with that patient, so that's where you should be most of your clinical day. Okay, we've talked about structuring, objective and subjective. We've talked about sources of data. Methods of data collection, we've talked about. Okay, so patient variables, we talked a little bit about pain or trouble breathing. If your patient has a lot of anxiety, okay, I can remember lots of times that I have to go in and see a COPD patient or somebody who has trouble breathing. And a lot of times they'll take anxiety medicine, Xanax or Ativan or something like that, once a day or twice a day or however scheduled, you know, and you'll hear a nurse, oh, she just wants her Ativan, and she doesn't want to go get it for her. Well, she needs it. She's anxious. She has trouble breathing, and once you get her that Ativan, she's going to settle down and be able to cooperate with you. Okay, so their anxiety is a real need that has to be addressed before you can have a relationship with the patient. Pain, language difficulty, previous negative experiences is something that's going to be huge for everybody that you meet in your life ever. So sometimes you just are talking to somebody and you're like, I get it. Like, I bet you have an abusive dad, or I bet like your last teacher really was mean and made you feel like an idiot, or whatever previous experiences you have can affect future experiences. So if your patient's in and out of the hospital a lot and they've had bad experiences, then they could be expecting that from you as well. So just be aware of that and see how, even for you, with your previous negative experiences, try to grow from those and move forward and not repeat or assume that those same experiences will keep happening. And unrealistic expectations. Sometimes we do have patients who think that it's the Hilton and we just have to smile and be polite and meet their needs. But when you have other patients who have real needs, I can't go get you the specific whatever sandwich or anything you need right now. Although nutrition is important, and it is important to make sure our patients have nutrition. I'm trying to think of an outlandish example, but really, I think they're pretty well behaved most of the time. Unrealistic expectations, probably a confused patient who wants to leave, who can't leave, and wants you to take them out of there, and tells you that they have a lot of money if you just drive them home. They can pay you. And then they punch the nurse that you're working with, so anything can happen. Okay, so we take all this data and we need to group it together, make inferences. Okay, here's all my data, this is what I think the problem is. Okay, this just talks about data validation, this is straight from your textbook, so there's a situation, like the blood pressure example that I gave. Okay, so my data was not accurate with that blood pressure because they were moving all around, so I had to recheck it. This example here talks about abuse. Patient may be afraid because her husband is abusive. Okay, they're quiet and they recoil when the husband touches her, and then literature describes those behaviors as clinical manifestations or signs and symptoms of abuse. So you say, I can't help but notice how quiet you are whenever your husband is here, and you're even pulled back from his touch. It seems like you're afraid of him. And then they begin to talk about her fear and her husband's abusive behavior. So that was validated. So we had a hunch from what we were seeing, and then we talked to her about it, and then that is what happened. Okay, again, so when we cluster data and identify patterns, we're gonna use Maslow. Okay, so do they have a physiologic problem, which is really gonna be our main focus. Okay, safety is a close second, so they're always at risk for injury or risk for falls. Okay, that's a close second, but an actual physiologic problem is always gonna be a higher priority than a risk for problem. Okay, so problems with oxygenation, problems with perfusion, so the ability of blood to circulate through the body. Elimination, nutrition, sleep. Okay, all of those things are physiologic and high priority. Okay, we can develop them into different concepts that are starting to be familiar to you: nutrition, elimination, exchange, activity or rest, perception or cognition, safety, comfort. Okay, we can group things into body systems. That's the meat of it. The rest of this we'll get through pretty quick. We have a short Kahoot on assessment. Does anybody have like Alexis? Can you guys hear me? Because I did not turn this back on. Okay. Okay, examples of subjective data. We have subjective and we have objective. Patient tells the nurse that she's feeling nauseous. Okay, perfect. Patient vomits after supper. We have validated that nausea with some objective data, right? Because they vomited. Swollen ankles, that's objective. And we can see that they're either swollen or not swollen. And a blood pressure of 176/90 is objective data, numbers. Assessment is the continuous collection of patient data. Okay, that's true. The patient's family can help you collect data, give you information about the patient. Maybe even they'll help you like position the patient, whatever it may be. It just depends on the patient and the family member. But if they are able to help, then you should take their help. partial ongoing assessment. Focused assessment, it is kind of a focused assessment, but on that slide, we talked about how it's a partial ongoing assessment. So when they're in the hospital, we're continuously assessing. I'm gonna have to reword this one, maybe. Okay, so this one's kind of tricky. So like their address, their medical history, their medications that they take. Once we collect those are in, and they should be in there. We don't have to ask them again because they've already done it and it's in there. But we do have to verify, right? And we do have to, so even though, you know, the night shift nurse has her vitals and her assessment documented, we then do have to go do our own vitals and our own assessment. So I can see how this one is kind of tricky. But I was thinking when I wrote it, like the H&P, their medical history, their medicines. So that's why it would be true. Good, perfect. Okay, nauseous is subjective. Patient states they have pain is subjective. I'm sorry guys, that's getting really bad. Is subjective. We can make it objective by using a scale, right? If that said the patient's pain is 2 out of 10 or something, then you could argue that that's objective. Same with the headache. Okay. All right, so diagnosing, not to be confused with the medical diagnosis, okay? It's an actual or potential problem, diagnosis, or issue. Okay, so you'll hear nursing diagnosis also referred to as a patient problem or a priority problem. Okay, there's collaborative problems. Okay, so just know that terminology, but our focus is a nursing diagnosis. Okay, so basically it's a health problem that requires an intervention. Okay, in your fundamentals book, on page 369, there's a whole list of NANDA, North American Nursing Diagnosis Association. Okay, so the nursing diagnosis. On 375, there's a glossary of terms for NANDA. I think that's in your assessment booklet. Okay, and then you have the handout that I gave you. Okay, and then you also have Lippincott, right? And it's separated by like a category of functioning or concept. Okay, so you have lots of resources. You just have to use them, work with them, get familiar with them. Okay, so we talked about how there should be a related to and an as evidenced by is the real way you write out the whole nursing diagnosis specific to your patient. Okay, so before you can do that, you need patient data. Okay, medical diagnosis remains the same from day to day. If they have pneumonia, they have pneumonia. Okay, but for us, they could have impaired gas exchange or an ineffective breathing pattern, and that could change while they have pneumonia. They could get better or worse. Okay, but pneumonia is always pneumonia. Okay, so if a patient has a myocardial infarction or an MI, which is a medical term for a heart attack, okay, so that's their medical diagnosis. Okay, so there is a clot in the vessels that supply their heart muscle with oxygenated blood. Okay, so there's a clot someplace in there, so it's blocked off. Okay, so that's what causes the heart attack. That part of the muscle is not getting oxygenated blood, so it kind of dies, it quits functioning. Okay, so they're having pain, they're not adequately pumping blood through their body. Okay, so the medical diagnosis the nursing diagnosis that we are concerned with about that is going to be altered tissue perfusion. saying, that's just some terminology that you have to get used to. Okay, so the tissue we're talking about is cardiac tissue. Okay, it's altered because it's not normal, right? It's supposed to flow through, it's not because there's a clot. Perfusion just means, okay, so oxygenation means I'm taking oxygen into my lungs, and then perfusion means that as that blood goes through my lungs and picks up that oxygenated blood, that oxygen, it takes it to the rest of my body. It perfuses it to the rest of my body. Okay, so they have altered tissue perfusion. That's what I'm concerned with. That's their response. That's what their body is doing. Okay, altered tissue perfusion related to MI as evidenced by, and so the data that knows that how we know that's a problem, you could have one thing, you could have lots of things. Okay, the main thing is gonna be an EKG. Okay, they're gonna have an EKG and it's gonna show that they have a blockage. Okay? Or a cardiac catheterization diagnostic test. Okay, what the patient could be showing is chest pain. Could be how you know. Okay, or maybe they're pale because they're not having perfusion. Okay, another nursing diagnosis that we would be concerned with is fear. Okay, fear related to MI as evidenced by, in quotes, patient states, I don't want to die. I'm afraid I'm dying of a heart attack. Or deficient knowledge. So deficient knowledge is a blanket nursing diagnosis that you can use for every patient, every day, in every situation. Okay, it's usually going to be deficient knowledge related to a medical diagnosis, or related to a medication, or related to a treatment. Okay, so they have deficient knowledge on this. We need to educate them on it. Okay, they were newly diagnosed with diabetes, and they don't understand how to take their insulin shot. So deficient knowledge related to administration of subcute insulin. Okay, so your whole nursing care plan, your plan is going to be that they learn how to take their insulin. Okay, so all your interventions are going to stem from that plan and that diagnosis. Okay, another example, if a patient has a bathing self-care deficit. Okay, we talked about Dorothea Oram and her theory of self-care deficit. So it's reasons for why people need nursing. You're supposed to be able to take care of yourself, your range of motion, you're getting dressed, you're eating, your hygiene, all of those things. And if you don't, you can have a self-care deficit. Okay, you can have a blanket ADL self-care deficit, or you can pull out specifically, like this one is bathing specifically. Okay, so the cause for this one, the etiology is known as the cause. It's usually a medical diagnosis, but it could be just a problem. Okay, so they have a bathing self-care deficit related to fear of falling in the tub and obesity. Okay, so typically more you'll just see related to obesity. They just physically cannot bathe themselves. Okay, but they could also have a fear of it also, so that's why they don't do it. Okay, there could be one, could be multiple reasons. Okay, and then the defining characteristics are the as evidenced by or as manifested by. So in this example, the data that we collected, the patient has a strong body odor, strong urine odor, they have unclean hair, and they verbalize, I'm afraid I'll fall in the tub and break something. Okay, so the whole nursing diagnosis for this problem that we've identified, and remember, each patient can have tons of different nursing diagnoses, tons of care plans, okay? For the most part, in our documentation, we pick the highest priority and it's a flow sheet, click, click, click in your computerized system. Okay, so for the most part, we're just thinking about these in our head and with our actions with our patients. So you're not sitting down and writing out these plans. Okay, you're thinking about them. In nursing school, you will, so that you learn them, but you're just thinking about them. It's usually a click, 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 once a shift. Did you document your care planning today, they say. Okay, so it's documented, the high level ones. And as you get through these, you'll see that the high level ones include information about the other level ones. Okay, so it is comprehensive. Okay, so this whole thing is going to be bathing self-care deficit related to fear of falling in the tub and obesity as evidenced by strong body and urine odor and unclean hair. Okay, so that's your complete nursing diagnosis. So you've taken it from Lippincott at this point. You've made it specific to your patient with the data that you collect. Okay, and then you have to have a plan. Your plan has to be directly related to your problem. Okay, so if your problem is that your patient has a self-care deficit related to falling and obesity, and this is why, your plan is going to be for the patient basically to have hygiene, right? So we recognize that they have a self-care deficit, so our goal is gonna be that they receive or participate in, and that's gonna depend on the patient. Is it something that if we give them adaptive equipment, like a shower wand and a handheld brush, that they can do it by themselves, or are they gonna need all those things and they're also gonna need a nursing assistant to help them bathe? Okay, so that's gonna be specific to our patient, and then that's what our goal is gonna be. So our goal is gonna be that the patient maintains cleanliness and hygiene with the assist of a nursing assistant 3 times a week. Okay, so whatever, it's gonna be specific to the patient. Okay, and then all of our interventions are gonna focus on that plan here. Okay, so your nursing diagnosis and your plan and your interventions, you will find in Lippincott, but you have to use a lot of critical thinking and your patient data to make them specific and make sense. Okay, for prioritizing, we hit on this a little bit the other day. Highest level would probably be if we have a patient who has an ineffective airway clearance, okay, which we don't really ever see. It's if a patient is actually choking. Okay, next level down, we're gonna see impaired gas exchange or an altered breathing pattern. Okay, so airway, breathing, circulation. So if your patient has impaired gas exchange, we know because their pulse ox is abnormal, okay, or there's other lab work that we can tell. If they have an altered breathing pattern, the data that we would use to recognize that is a respiratory rate outside of that 12 to 20 normal. Or they verbalize that they're short of breath. Okay, they can't do regular activity without getting short of breath. Okay, maybe they have retractions or uneven, or you can see that they're physically using accessory muscles and working hard. Okay, and then below that in circulation is gonna be the altered tissue perfusion that we talked about. Okay, that can be specific to a location like cardiac or lower extremities. So if your patient is obese and has cardiovascular disease and they don't have good venous return, they're at a risk for a blood clot, okay, they're gonna have altered tissue perfusion to their extremities. Okay, hypotension is one of those tricky ones because it's a patient problem and it's also a sign, symptom, medical diagnosis, okay, you'll just get used to some of those. So if they have hypotension, that is an actual problem and we are concerned with that. If they don't have any of these ones higher level than that, hypotension is a priority problem, so low blood pressure. Okay, below that, maybe 100 systolic, maybe 90 some people are okay at, and then the diastolic, the lower number, below 60 maybe, okay, we're looking at trouble. Excess fluid volume is a common one that you're gonna see. Your patients that have swelling in their legs, maybe they have swelling in their, and fluid in their lungs, okay, and have a hard time breathing. Excess fluid volume. Their fluid volume is not equal, they don't have equilibrium, they have extra third spacing fluid, and that's gonna hinder perfusion, it's gonna hinder oxygenation. Okay, so weight is the main way we would know if their weight increases drastically. Actual edema that we can see, lung sounds can let us know, lab work sometimes. Okay, a risk for hypertension, if we have a patient who takes 10 high blood pressure pills, okay, and their blood pressure is always like borderline, we know that they're at risk for hypertension. Okay, so if I don't get their meds on time, their blood pressure could go up. When your blood pressure is higher than normal, it's just blasting through your vessels and your organs, it's gonna cause organ damage. Venous thromboembolism risk. Okay, so pretty much every patient in the hospital is at risk for thromboembolism or a blood clot because they're not up and around. Okay, they're laying in bed. Okay, more common problems just pulled off your list. Acute pain, nausea is a problem. Okay, these are missing the related to and the as evidence buys. Those are going to be specific to the patient. They can change every time. Okay, so work with some of those. Try to come up with some of those. Okay, and then there's risk fors. Remember that a risk for is always a lower priority than an actual nursing diagnosis. Okay, but these are all common. All of our patients are gonna be risk for falls. They're in a new environment, they're hooked up to at least one thing, okay? They're usually weak, they're definitely at risk for falls. Risk for bleeding, a lot of our patients take blood thinners because they've got the history of the blood clots and the heart attacks and the cardiovascular disease. So to treat that, we're gonna give them a blood thinner, but now on the flip side, we know they're at risk for bleeding. Okay, so we're gonna be very cautious with them. Risk for pressure ulcer, right? Because they're bed bound, if they don't have good nutrition, if they're not continent of stool and urine. Risk for infection, everybody, right? Because they have an IV, they don't have intact skin. Risk for aspiration means choking. Okay, if your patient had a stroke, if they're unable to position themselves in bed and somebody leaves a tray and they're laying down and they try to eat their tray because they're starving and nobody helps them sit up, they're at risk for aspiration. Risk for caregiver role strain gets higher up on Maslow's level. Okay, it's not as much of a concern for us, especially inpatient. Risk for deficient fluid volume, everybody. They can't get up and get their own water. If we don't take care of them and keep that water pitcher filled, they're at risk. Risk for constipation, again, the immobility. Patients who take pain medications are at risk for constipation. A lot of our hospitalized patients don't get adequate hydration and nutrition, risk for constipation. Okay, so a risk for has a related to, does not have an as evidenced by part because it's not actual. It's just a risk. It's not occurring. Okay, so as you work through these and create nursing diagnosis, your actual is going to have problem related to as evidenced by. Your risk for is going to have risk for blank related to blank. No as evidenced by. Okay, I filled these out. I finished them through. You can look at these examples. Okay, informatics is the use of, so we have standardized language and electronic health records. So now it's there. NANDA is built. NANDA wasn't always there. Theory and data collection, we were like, oh my goodness, we're seeing these problems, and we're seeing these problems. Oh my goodness, this causes this, and this relates to this, and these are the interventions. That didn't used to all be there. Okay, so now it's all there for us. Depending on where we work, it'll just be a click, click, click. This is the care plan. Usually when a patient is admitted to the hospital, we do an admission assessment. It pulls all that data and recommends nursing diagnosis for us. Okay, you filled out all this, we think your patient has this problem, you wanna use those, yes or no? And then all you have to do is individualize it to your patient. Okay, I have a review, we can do this on Tuesday. Okay, planning, we go through everything that we've already been talking about. This is my problem, I want the problem to be resolved. Okay, so when you're working in one care plan, your plan should be for that one problem. Don't blur it with different problems that are occurring at the same time. Okay, so all those interventions are gonna work to accomplish my outcome, my plan. Okay, we need to use clinical reasoning. What needs immediate attention? What will happen if I wait to do it? What's my responsibility and what can be delegated or referred out? Okay, when we write outcomes, we're writing something that should be specific, measurable, attainable, realistic, and time-bound. Okay. And there's gonna be a variation of how specific we can get depending on our patient situation, depending on the problem, depending on how much time we have with them. Okay, some examples of goals that you would write. So if the problem is acute pain, maybe a goal is that the patient's gonna let me know before their pain becomes unmanageable. Okay, kind of vague. More specific is the next example, which we already talked about. Okay, examples of outcomes for a patient with nausea. Okay, make sure you read through these. Examples of an outcome for a patient with activity intolerance. Okay, you can read these just as easily as me, so I'm gonna scroll through. Okay, so when we're planning interventions for an actual problem, we wanna reduce or eliminate the contributing factors, promote a higher level of wellness, and then monitor and evaluate status. So when we come up with a problem, a diagnosis, one of our main interventions is gonna be to monitor that or to assess that. Okay, so if they have some type of respiratory problem and I identify that they have a impaired breathing pattern, okay, or altered breathing pattern, one of my interventions that I'm gonna plan to do is to assess their respiratory status or monitor their respiratory status. Okay, and as you're pulling out interventions, you have to read all the way through, and some you can pull together and mix together. And you've gotta read all the way through and then see what fits to my patient. Okay, so you could say assess respiratory rate, assess pulse ox, assess respiratory lung sounds, or you can just pull it all together and say assess respiratory status, right? Because that includes everything. Okay, so look where you can save yourself time and group things together. Now, if you don't know that respiratory rate, pulse ox is part of a respiratory assessment, then write it out so that you learn it. But if you're like, yeah, I know those things are part of a respiratory assessment, I can just put assess respiratory status. Okay, for risk 4, we want to reduce or eliminate those risk factors, prevent that problem from happening in the first place, and then monitor and evaluate status to make sure it hasn't occurred. Okay, implementation is when we do the things. Okay, so we're implementing all day long. Okay, we can evaluate in the implementation stage, we can assess in the implementation stage. Okay, it's when we do the things. We've talked about that. Here's an example of a whiteboard that you might see in a patient's room. Okay, if it's not updated when you go in to see the patient, then you can go ahead and update it for them.
Do we put our information on the whiteboard?
Yep, it has pain, it has their activity level, their goal and plan for the day. So this is kind of like a quick, so when we're doing, hopefully they do walking rounds. So when you go from shift to shift, I'm going home, Gretchen's coming in, we're gonna go in the patient's room together, and I'm gonna have my notes and she's gonna have her notes, and the patient's gonna be there, and then you can see the patient as I'm giving you the report. So this is Betty, she's here for pneumonia, she lives at a nursing home, she was trying to take oral antibiotics, but she couldn't kick it, so she's here, we're giving her IV antibiotics, she's getting breathing treatments, she's on oxygen, she didn't have any of that before, so that would be new for her if she goes home. Her activity is she's up with one person and a walker. She's getting therapy. This is her diet order. Okay, so all of those things that are important to know for the hands-on care of the patient should be right there. So that anybody who has a little bit of clinical experience, if there's a light on and it's not our patient, we can still go in the room, look at this board, and if it's up to date, then hopefully maybe we can take care of that patient and that call light stops right there and the patient's needs are met. Sometimes we have to turn it off, see what they need, and then go find someone else. Okay, we can't always fix the problem, but sometimes we can. Okay, for you, you're gonna wanna say this a lot. I've never practiced that procedure, but I'd love the opportunity to observe one of the experienced nurses do it. Okay, especially in your first semester, there's not a lot of things you're gonna be checked off for. Doesn't mean you can't tag along with somebody and go see it. Okay, so make sure your patient is taken care of, their vitals are in, their assessment's in, their I&O for breakfast is in, their bath is done, their needs are met, and then if anything cool is going on, you can follow around and see what's going on. Okay, we gotta use our time wisely to maximize each patient encounter. Okay, these are examples of implementation. These are pulled from Lippincott, specific to like acute pain. Okay, so if I have acute pain, these are the interventions I might be doing. Okay, some might apply, some might not. Read through all of these. Make sure they make sense to you. The implementation verbs we've seen before. Okay, the review you can do on Tuesday. Okay, and then evaluating. So we're continuously evaluating. It's really not like at the end, we're gonna evaluate. We're always evaluating. And then we're either gonna terminate the plan because they've met their goal, we're gonna modify it because some things are working, some things are not, or we're just gonna continue with it. Okay, we're doing good. We're not at the point where we can terminate it. So maybe they have acute pain because they had surgery, but several days out, they no longer have any pain. So we can terminate that care plan, it's not an issue anymore. Okay, examples of evaluation. So when we go back and evaluate, this is what we find. Okay, so it's gonna be exactly what, a mirror reflection of what our plan was. So I planned for that patient with pain, that they maybe identify factors that increase pain so they can stay away from them, or state and carry out ways to decrease pain. Okay, so I planned for them to do that, and when I evaluate, that's what they did. Okay, it's just a circle rewriting the same words in a different way. Okay, examples for evaluation of nausea, activity intolerance, excess fluid volume, risk for falls, risk professionals. Okay, some more examples. Okay, so just going through the assessment process. So I have a 76-year-old male with a past medical history of urinary incontinence, so they can't control their urine. Falls, OA is osteoarthritis. Everybody gets osteoarthritis eventually. Stiffness in the fingers, different places in your body, in your bones. Hypertension is high blood pressure. Okay, so he was admitted to the hospital unit earlier this afternoon with a UTI, which is a urinary tract infection, and an elevated BP, so high blood pressure. He was not on any home medications. Okay, he fell at night getting up to use the bathroom. He got up quickly, became dizzy, tripped over electrical cords. Okay, his vitals at the time were 99, 110, 26, 180 over 76, 97% room air, and 10 out of 10 sharp right lower extremity pain. Okay, so in this situation, I've identified acute pain as a priority problem. Okay, so what's my goal gonna be? What interventions will I do? For this example, I would assess the pain, determine the cause of the pain, provide comfort measures, encourage rest, administer analgesic, which means pain medicine, maybe prepare for surgery if he broke that leg. Okay, so in our evaluation phase, we assess how they responded. Okay, so it could be something like they report a 1 out of 10 pain after resting quietly in bed, doing imagery exercises. Okay, so picture yourself on the beach or whatever it may be. An administration of morphine 4 milligrams IV. Okay, so these are all the interventions I did. Their pain went down. Okay, or maybe they still have 10 out of 10 pain after all of those things. Okay, so I'm evaluating and reassessing at the same time, and now I also need to give them an ice pack and hit them with some hydromorphone or Dilaudid, just stronger than morphine, okay, and see how that goes. Okay, so in this case, I've evaluated or reassessed and they're good, my goal was met. In this case, it wasn't, so what am I gonna do now? I need to modify. Okay, there's another example. Make sure you read through this because this situation will happen to you in clinical, so make sure you know what to do. Another example, and then this just is a cute picture. Okay, a lot of times all it takes is just boosting that patient up in bed because they get slumped down in that bed and they can't breathe and their lungs get junked up and their vitals go crazy and they're uncomfortable. So it just boosting them up in bed and getting them in a comfortable position can make all the difference. All right, you guys have any questions about anything? This is almost out. You have a good memory? Please don't take it. I posted the video of yesterday's lecture. I did listen to part of it. It is pretty good. If I don't say thumbs up, make sure you listen to that and understand it. So by tonight, I should have today's lecture posted. So by then, you should have everything ready for your first exam. Make sure you go through and listen to those or watch those, especially if you don't feel like you took good notes. Because I talk a lot and I talk fast, and there's a lot of stuff that I say that's not on your slides that could be on your test, okay? So for the most part, I do like to pull out the most important stuff, but just so you know, anything that's in any of your assigned readings is gained for your exam. Okay, so make sure you have an overview. Hopefully, when you started, you looked at all your readings, you looked at all the pages, made an outline, know the main ideas, and then come to class and get to know more of the details, and then go back and read again and clarify any misconceptions you had. And then you're testing yourself on Prep U. And you wanna get up to level 4, maybe level 5 of your Prep U and all of your chapters.
And that's everything together. Yeah.
Yep. Okay, so we'll have a review on Tuesday. We can do the Kahoots that we didn't get to today. And then we'll do, most likely what we'll do is Prep U